Estrogen withdrawal syndrome is the number one hormonal cause for pain and suffering in a woman's lifetime. Estrogen withdrawal syndrome is triggered by dramatic decreases in estrogen levels postpartum, a surgical menopause, that is removal of the ovaries, and then the most common perimenopause and menopause. Rarer causes of estrogen withdrawal syndromes are when anti-estrogen drugs are given to women. This can be in the form of progesterone, which is an anti-estrogen, the synthetic progesterone, or even fertility drugs like Clomid. Estrogen withdrawal syndrome is managed by the administration of the lowest dose of natural, biologically identical, non-oral estrogen that meets the individual woman's needs. The estrogen zone, we start with a woman coming in and we know her estrogen is low. And the low symptoms, the first that are corrected with the lower doses, are the physical symptoms, the hot flushes, night sweats, and sleep disturbances. A little more estrogen may be required for the psychological and emotional symptoms, anxiety, irritability, and depression. But I found that the most estrogen was required to improve the woman's cognitive function. This includes thinking clearly, staying focused, and completing a task. These are the early menopausal estrogen deficiency symptoms. If a woman does not take estrogen at that time, and she goes into midlife in her 60s and into her 70s, she may suffer various atrophies, bladder atrophy, vaginal atrophy, and skin atrophy. The bladder atrophy would result in urinary frequency, urgency, or incontinence. The vaginal atrophy would result in a dry vagina and pain with intercourse. And then the skin atrophy is the all too common wrinkling of the skin. If we look at the later years yet, a woman in her 70s, 80s, and 90s, with estrogen, we could eliminate premature death. So estrogen after the menopause, allows a woman to live longer. We could prevent atherosclerosis, or what they call hardening of the arteries. This affects both the heart arteries. When they get clogged, results in heart attack, and it also prevents plaque buildup in the carotid arteries, which feed the brain, and when they get clogged up, leads to a stroke. The heart attack is the number one cause of death in women after menopause. Stroke is number 3. So if we could prevent the plaque buildup in a woman's arteries, we could have a major impact on the number 1 and 3 causes of death in postmenopausal women. As in the later years, we have to worry about osteoporosis and fractures. Usually the first fracture that happens to a woman as she ages would be in her spine, and these are very hard to diagnose. The next fracture is to the wrist. When a woman knows she's going to fall, she extends her arm and falls on her outstretched arm and fractures her wrists. And then the most common thing that we fear so much about is the hip fracture. And this is talked about so much because it is often fatal to a woman. Other things that aren't talked about so much, but I have found very effective, is the prevention of Alzheimer's, which is one of the major concerns of women as they get older. I have not seen any diabetes in my patients, and I have seen a very low incidence of colorectal cancer in my patients taking estrogen replacement. The Quigley method of hormone replacement enhances the quality of life for symptomatic women with PMS, perimenopause, postmenopause, or postpartum depression. We start by initiating the lowest individualized dose of each non-oral bioidentical hormone, one hormone at a time, as each woman monitors her daily symptoms on the Women's Awareness Calendar. We meet regularly. If a woman is still, if she has stopped her cycle, we can meet every 2 weeks. If it hasn't corrected itself within 2 weeks, it's unlikely to correct itself. But if she is still having her menstrual cycle and we have to watch that hormonal cycle, we would meet each month at about the time that she would expect her period, so we could make the necessary adjustments to have an impact on the subsequent cycle. We maintain these individual hormonal zones by giving each woman permission to fine-tune her own dosage of each hormone depending on her specific life stretches, just as we give a diabetic permission to adjust their own insulin dosage. As a woman ages and gets beyond 65 years of age, I then may taper their dose, because we know that the metabolism of an individual slows down with aging. The question I had when I left academic medicine and went into private practice was the decreased quality of life a woman experienced during her 40s hormonal or just due to aging? I've found 25 women who had both their ovaries removed before age 40, and we determined a quality of life scale on a scale of 0 to 10. On no estrogen replacement, the women reported a 0 to 3 of 10. On estrogen only, the women reported a 3 to 7. What was missing? They reported a decreased energy, decreased libido, decreased motivation, and a decreased zest for life. All 25 women had undetectable levels of testosterone in their circulation. When we administered testosterone and got the correct dosage for each individual, every woman reported a 10 of 10 quality of life. This is partially why I'm so annoyed with studies like the Women's Health Initiative, where they give tens of thousands of women the exact same amount of hormone or not. With the testosterone zone, we found that the earliest symptoms that were resolved was usually an increased oil to their skin, and then they had a slight increase in their sense of well-being. Their motivation then improved with higher doses, their energy improved, their vitality, but what they required the highest amount of testosterone, or it was to restore their libido. And then we had shock and horror come. The NIH had a news release that was sent out on Tuesday, July 9th at 9:30 in the morning, indicating that they were going to have a press conference in about an hour later in Washington, D.C. The title of the news release was, "The National Heart, Lung, Blood Institute stops the trial of estrogen and progestin due to an increased breast cancer risk and lack of overall benefit." There were major differences between the women in this study and the women I saw in my clinical practice. And I'm going to just review some of these differences. The average woman I saw in my clinical practice was probably age 45 when I initiated her hormone replacement. But I did see women and start them on hormone replacement as long as they were between 40 and 55 years of age. That'll be apparent to you in the future presentation. In contrast, women in the Women's Health Initiative studies could be starting their hormones for the first time up to 79 years of age. They were between 50 and 79 years of age. They were too old and too late to be starting hormone replacement. My patients started the estrogen, I said, within 5 years of menopause. The average, the woman in the clinical trials we're speaking of were 12 years after menopause before they started their hormone replacement. My patients all had moderate to severe symptoms. The women in the Women's Health Initiative clinical trials had to be asymptomatic. The reason they were eliminated in a washout phase of 3 months, if they refused to stop their hormone, they were eliminated, or if they didn't stop their hormone and had significant menopausal symptoms, they were not allowed to enter because it was felt that they would not last the full 8 years of the study if they were in the placebo group. My patients were extremely healthy. The women that participated in the Women's Health Initiative were extremely unhealthy, and I'll review that in a few moments. I gave the lowest individual non-oral dose of each biologically identical hormone to relieve their menopausal symptoms. The women in the WHI hormone clinical trials received a single daily dose of oral estrogen, Premarin, from pregnant mare's urine, or Prem-Pro, a combination of the estrogen with the synthetic Progestin Provera. I have never given a patient that Provera, and that'll be very important as we move forward. My aim was to improve the quality of life of these women. And at the same time, I wanted to obey my Hippocratic oath, do no harm. In contrast, the Women's Health Initiative, the primary outcome was heart attack. Over 30 studies had shown that when women took estrogen or estrogen and progesterone at the usual time to reverse their menopausal symptoms, there was a 30 to 50% decreased risk of heart attack. The primary outcome concern with the Women's Health Initiative trial was breast cancer. The Women's Health Initiative postmenopausal hormone studies consisted of 4 parts: 2 short-term clinical trials, Premarin and Prem-Pro, estrogen, and then the estrogen with the synthetic progesterone Provera, and 2 long-term observational studies, estrogen only in hysterectomized women, and estrogen plus some form of progesterone in women who still had their uterus intact. If we look at the number of participants of the women in the Women's Health Initiative, and we look at the observational studies, we can see there were almost 94,000 women in the estrogen only and estrogen plus progestin portions of the observational studies, whereas in the clinical trials, there were a total of about 25,000 women. So just about a quarter as many women in the trials as in the much larger observational studies. But this information gave us something that I've not seen published anywhere else. They gave us the baseline health status in the Women's Health Initiative clinical trials versus their observational studies. The major difference between the clinical trial women and the observational study women was that the women in the observational study maintained their freedom of choice to choose to either take hormone or not. In the clinical trials, you were not allowed to choose. Your only choice was to enter the study or not. Once you entered the study, you were given either estrogen or estrogen plus progestin or a placebo. What I can tell you is that on this, that the health status of the women in the Premarin and Prempro clinical trials were much less healthy than either the controls or the hormone users in the observational studies. And that, to me, is critical. It points out to me that maybe there's a flaw in Western medical's research's plan that the best study is a clinical trial where the patients are randomly given hormone or not. I believe one of the most important God-given gifts is the freedom to choose. And this review of the baseline health status in the 4 studies would substantiate that. As you can see on this slide, the women who took the Premarin or Prempro were less healthy than either the controls or the hormone users in the observational studies. We can see on this slide that the weight distribution in the women's health Premarin and Prempro clinical trials versus the observational studies demonstrated that there were 14% more women that were normal weight. That is what they call a basal metabolic index of less than 25. There were 14% more of these women in the observational studies than in the clinical trials. The number of overweight women was approximately the same, but then the number of obese women was 13% higher in the clinical trial women. The clinical trial women weighed an average of 11 pounds more than those in the observational study, and the waist size was 6 inches greater. I think this is relevant. I think that when I talk about my patients and giving them individualized hormone replacement, these women were much more aligned with the women in the observational study than what we see in the clinical trial data that we just talked about.